program. So I am Jeannie Walker. I'm director of the program planning committee, and I have the great opportunity to be able to introduce you to Mary Kennedy, who's going to be speaking today. I'm excited about this because I think a lot of people would be very interested in what happens when we sometimes hurt ourselves or see someone else being hurt. So this is going to be very interesting. Mary Kennedy is a Ph.D. She is a speech-language pathologist, a researcher, and an instructor in communication sciences and disorders at Chapman University. She's at the Reaver campus. She originally is from Orange. She grew up here and graduated from CSU Fullerton with her master's degree. She worked for several years in working in rehabilitation. She attended and graduated then at the University of Washington with a PhD in speech pathology, with an emphasis in cognitive psychology, which is very interesting, the combination. She then spent 16 years at the University of Minnesota, where she continued her clinical research with individuals with traumatic brain injury, and authored numerous publications that describe evidence-based practice for cognitive rehabilitation. In 2011, she was invited by the Institute of Medicine, this is the National Academies of Science, to join a working group of medical professionals in order to create practice recommendations for the rehabilitation of individuals in the military and the VA. The 2011 publication of hers is titled Cognitive Rehabilitation Therapy for Traumatic Brain Injury, and summarized that very comprehensive work. Dr. Kennedy came back home here to Orange and to Chapman University in 2014. She has continued her research on how best to support individuals with cognitive and communication disorders after TBI, traumatic brain injury, including those with concussion. In 2017, she published a book titled Coaching College Students with Executive Function Disorders, which outlines a dynamic coaching approach that's now a standard of practice. Dr. Kennedy has years of clinical and research experience working with individuals with cognitive and communication impairments after brain injury. Her current work is focused on how to best support the recovery and rehabilitation of those with long hauler COVID symptoms. It's going to be very interesting to hear what she has to say about that. So, Dr. Kennedy, please.
It is really an honor to be here today. We had tried to set up something, I think, pre-COVID, and the schedules were just not working out, so I'm glad to be here for one of the in-person events. Okay. So a couple of just disclosures. Typically, we like to do this. The information today is based on my knowledge and opinion of the research in the field and doesn't represent any kind of official policy of Chapman. I have authored numerous publications that describe best practices for professionals working with individuals with traumatic brain injury, including publications in concussion, and I've authored a book that Dr. Walker shared with you, for which I received royalties, and I want to acknowledge my colleague and an expert in concussion and mild TBI, Dr. Catherine Harden. So let's look at the landscape of traumatic brain injury for a few minutes. Traumatic brain injury, or TBI, that's what we'll call it this afternoon, is an injury that affects the brain and how the brain works. And it's caused by a bump or a blow or a jolt to the head, or it can also be the result of some kind of penetrating injury, like a bullet. So there are about just over 5 million people living in the U.S. with disabilities related to TBI. In that, there are approximately 2.2 million new injuries annually. So if you look at those two figures together, then that also means that quite a few people are recovering, right? Which is the good news. In other words, they recover and they don't really have lasting disabilities, but there are enough that do, unfortunately. Of the new injuries that occur every year, of that 2.2, the vast majority of those injuries are what we call mild, and we used to use the word concussion. So through, hopefully in about 40 minutes or so, you'll leave this room thinking, okay, I won't call it a concussion anymore, I'll call it a mild TBI. Because it is a brain injury. It may be temporary, people may recover fully, but it is an injury to the brain. So TBI is also considered the leading cause of accidental death or disability worldwide. So I like this article because part of it, just the title attracted me. And the title is, "My child doesn't have a brain injury, he only has a concussion." Right. And so I think by the end of in the next half an hour or so, you'll probably, hopefully conclude with me that if you have a concussion, you've had a brain injury, but there are varying degrees of that. And we'll talk a little bit about that. We'll get a little deeper into what is a concussion, what is a mild TBI, what's a more severe TBI. So the language can be confusing, and I think it's, most of us would like to use the word concussion because our perception is that that is just temporary. That's a very minor little accident, right? We don't really want to use the word mild TBI or MTBI. So again, a concussion or a mild TBI is a bump, a blow, a jolt to the head, or a hit to the body that causes the head and therefore the brain to move back and forth. And it may move side by side, it may move forward and backward. So a concussion is this occurs in this from this violent jarring of the brain inside the bony structures of the skull. And that is what causes, in many cases, in most cases, a temporary disruption or a temporary problem in thinking, listening, understanding, and remembering. But this sudden movement causes the brain to bounce around, to move around within the skull. And when it does that, there's a stretching or a shearing, a pulling of the individual neurons. And neurons can be very, very long. And what happens then is that neuron, when it's stretched or sheared or pulled, the individual cell, something's happened to the membrane, the outside structure of that cell. And suddenly, because the membrane cell has been disrupted, there can be a pretty significant chemical change going on between the outside of the cell and the inside of the cell. So there are some fairly significant chemical changes that occur in a more severe brain injury, a mild or severe, but certainly in a concussion as well. Just one little aside here. So the science around mild TBI has advanced remarkably since the 90s. And when organized sports such as the NFL, collegiate athletes, and the collegiate organizations began to realize the significance of what at that point was called a concussion. And then at the same time, we were in a war in Iran and Afghanistan. So those two events that impacted our particular country really kind of brought the public attention of concussion to the forefront. we were having military service individuals return with not just a concussion, but also PTSD. And so then there was this really wonderful effort in trying to figure out, well, is it PTSD or is it concussion, mild TBI? And then eventually the research showed that actually they can be in tandem. So individuals can have mild TBI and PTSD and be a veteran or service military, and they have very unique and kind of specific groups of symptomatology, and they need very unique and specific kinds of support. So that's kind of how the attention began to shift around mild TBI or concussion. I did an interview in Minnesota many years ago with a radio station, and I remember the person interviewing me said, well, I don't understand, how come we don't know more, we don't have more research and information on these service military that are returning from war? How come we only have sports injuries? That was the only, and I was a little caught off guard by that question, and I said, because the research in traumatic brain injury, including mild TBI, has been underfunded for 40 years. And when you have an underfunded but a high incident problem, at some point, something will happen to raise public consciousness and give the attention of medical professionals, and that is what happened with the war. So for a while, we were only just kind of focusing on the sports-related mild TBIs, and then the war came, and then all of a sudden, everybody got involved in the conversation and got concerned. And that was a good thing. So the advancement of the science has just exploded. So this is a slide that shows, if you look down here at this, this is normal, and these are chemical changes in the brain. And what you see at the time of a concussion or mild TBI, you see a sudden change in calcium, sudden increase in calcium and potassium, sodium, and glucose increases a little bit, and it goes down as the minutes travel on. But here, look at this, cerebral blood flow goes down. That's not a good thing, right? So you don't have to be a biologist or a researcher to understand that any kind of big deviation or big change from normal is a dangerous situation. And but then you notice that around day 6 or 7, boy, people really begin to physiologically, kind of their brain begins to go back to its normal resting state. Well, this is an image of, this is someone who's had a severe brain injury. This is someone who's had a normal brain injury. And, you know what, let's see the next one, there we go. And this is someone who's had a mild traumatic brain injury just a few days after their brain injury. So this is the concussion group. And again, you can see that actually their brain, the metabolic activity, the actual what's going on in the brain for someone who has a concussion or mild TBI looks very much like a more severe brain injury than it does a normal. Now, again, this changes, right? It does change. And it does come back to some normal resting states for the majority of people who have mild TBI. So what is a mild TBI, and how is that different? Are there different kinds of mild TBI? So the typical concussion that we use, that terminology we use, in the medical field, we now call that an uncomplicated mild TBI or MTBI. So There is a change in neurological status at the time of the accident, but there are no structural findings, meaning there's nothing on an MRI, magnetic resonance imaging study, or a CT scan that shows up. And so that's really good news, right? And it is good news. It's good news for families, but it doesn't necessarily mean that the person will recover completely or will recover completely neurologically right away. So it is considered the mildest and the most common of all of the TBIs. Most people, the very majority of individuals who have these experiences end up recovering quickly, within 2, maybe 3 weeks, completely. And they have a Glasgow Coma Scale score. This is a very standard, international, well-validated, quick kind of way of assessing someone's neurological status in the emergency department. And so it's a high score, and that means they're very, very mildly impaired. Someone who has a little more difficulty than that would be someone who gets diagnosed with what's called a complicated mild TBI. And that presents with concussion, so all of these over here, but now the imaging results show something. So the MRI, and depending on the sensitivity of the MRI and the size of the magnet that's being used, it may or may not show as much or less, but if anything shows up, any kind of little bleed, any kind of little pulling or stretching of those neurons that are actually now visible, then it automatically gets the diagnosis of a complicated mild TBI. For people who have this kind of middle category, their recovery is going to be longer. It will be. It doesn't mean that they won't recover completely. They absolutely may, and that's the good news. But a higher percentage of individuals who get diagnosed with this may have what we call protracted symptoms, or symptoms that last a very long time. So what are these possible persistent symptoms? First of all, there's a whole collection of symptoms that we'll talk about in a minute, but they vary widely. They're very individualized. Someone can have mostly just problems with their eye movement. Another person can have problems with migraines. Somebody else can have problems more with their attention and fatigue. So they vary widely. Post-concussive syndrome is a unique category, which is a part of the persistent symptoms. And I won't spend too much time talking about that, but anyone who is a part of a mild TBI clinic or a concussion clinic, everyone who goes to any of these clinics or programs would be tested for persistent concussive syndrome. For individuals with persistent problems, as the heading suggests, symptoms can linger, and more symptoms are going to linger than you would expect from someone who's had a mild TBI. And I'll just make a point here, and I'm going to come back to this in a minute. Early on in concussion, mild TBI work, back in the 80s, a lot of individuals who had TBIs, who had mild TBIs, were dismissed. Their complaints were dismissed. And medical professionals, we didn't always believe them. Why? Because nothing showed up on their MRI, on their imaging, and the tests that we typically give were not sensitive enough. We still have trouble with that. We're still struggling with trying to find the right test. But we have come around, including an NIH, National Institute of Health, has come around, Department of Defense and Institute of Medicine has come around and said, you know what, we need to be paying attention to what people tell us. And we need to look at aspects like, this was a person who was fully functioning, had a job, taking care of a family, taking care of their grandmother or whatever. And suddenly, and then they fell and they hit their head, and now they're having these problems. I don't think they're making it up. This person doesn't want to be unemployed. They don't want to not care for their grandparent. I mean, so we've kind of come around and realized, yes, standardized testing is important and we need it, but also self-report and good surveys and questionnaires. And this has been embraced so much that there's this whole movement and a lot of research around patient-reported outcome measures at the level of NIH. So it's real and it's good news. So let's talk about what happens after a mild TBI. There could be physical, cognitive, and emotional changes that are going to improve with time. But the question is, well, how long is it going to take? And how many of these symptoms could one possibly end up with? So I was telling the group as we were talking about what I should focus on today, I'm going to try to keep it really light on research, but it's really hard for me to do that. So all I really want you to see here is these are all the different cognitive and emotional symptoms that anybody reported at any time right after a concussion or mild TBI. What I want you to notice is these two on the bottom here. So all across the board, there is a percentage, a little more than 10, 20, a little less than 10, that remain a problem for some people, this percentage of people, many days out. So 28 days and then even 90 days, that's 3 months. So it's not a big percentage, but remember that you have 2.2 million. The majority of those people have mild TBI. If 10 to 20, maybe even 30% of those individuals have these problems, that's a big issue for us as a society. Of course, we know it's a big issue for the individual, but just collectively, if you think about that number, it's a pretty big number. So here are the primary kind of categories or prototypes that have come out just recently in an article by Lumba Brown and colleagues. And there are 4 kind of conglomerations of symptoms. And so there are people who have cognitive problems. There are people who have ocular motor, meaning eye movement problems. And that's because the brainstem holds and contains all of those pathways that are going up and down from your brain to the rest of your body. But really importantly, the vestibular system and the eye system, those little pathways are instrumental right at the level of the brainstem. And you remember in a concussion, the head rocks, and it rocks right at the brainstem, right at that bottom part of the brain. I don't understand why we have not created these very large necks for ourselves. I think that would really help us all if we just had really big necks. But we don't. And so maybe 100 years from now, we will look very, very different. Okay, so there are also people who have headaches, the headache and migraine kind of syndrome. There are people who have dizziness and vestibular problems. And then there are also individuals who have predominantly the anxiety and the mood issues. And of course, individuals rarely have just one of these. It's usually a combination of them. And often with the college students that we work with, we've seen the anxiety and the mood issues be related to the cognitive problems or related to the headaches, right? When you don't feel well and you're not what you used to be, it can be very upsetting, right? So the cognitive changes after a mild TBI are numerous. There could be attention changes, processing speed, they're just a little slower. And all of their processing, they get overwhelmed cognitively, meaning, oh my gosh, there's too much stimulation on here. I can't handle the bright lights. because my eyes aren't, I'm not able to take in this information. So sometimes you'll see individuals inside who wear sunglasses, or they have a baseball cap on with sunglasses. Not a big deal. They probably have had a concussion and they just need to kind of dim those sensations for a bit. They can have memory and learning problems. Absolutely, because we know that after TBI, memory problems are kind of ubiquitous with traumatic brain injury. They can have executive function problems, so those frontal lobe abilities that we have that help us plan, stay organized, set up our schedules, get to appointments on time, decide what we're going to say or not going to say, so kind of that inhibition piece. And then that emotional regulation is all part of the frontal lobes, and that can be a problem as well. I put fatigue in here. Not everybody includes fatigue, but boy, the students, the college students with brain injury that we've worked with, especially the folks with concussion, have a big problem with fatigue. They get very, very tired quickly, and sometimes it's related to being cognitively overwhelmed. So this is just basically what I just said. Kind of gives you a little more detail. Attention problems, the person may lose their internal train of thought. So sometimes the attention isn't visible in an activity. Maybe it's just in their head. Now they've lost what they were going to say. They're having trouble multitasking. First of all, we're not supposed to multitask, right? Everybody knows that, right? That we're not really built for multitasking, even though we force ourselves to do it. But then, as we call ourselves neurotypical people who are aging, right? That's we're typical, and we're getting older, and we, of course, are going to we're losing that ability to multitask. Well, a lot of these are young adults, and they're multitasking all the time. They're checking their phone, they're on email, taking pictures, they're doing selfies, and of course they need their train of thought. They could do all of that before their injury, and now they can't. They're slow to process, and if you're slow to process information, so for example, in a conversation, suddenly you either self-isolate and you just don't participate, or you say something at the wrong time, and everybody looks at you like, what? We just talked about that. So they can get overwhelmed pretty easily, and what's called foggy brain, kind of what we're hearing about in some of the people who have long COVID, that foggy brain kind of fatigue phenomena. We talked a little bit about the memory and learning issues and the executive function problems. The speaking and word finding and reading and writing. So you may at some point think, why is a speech pathologist talking about all of these things that are cognitive, right? Well, it's because historically, occupational therapists and speech language pathologists way back in the 70s, we were the ones actually that started cognitive rehabilitation, believe it or not. There were only about 4 hospitals, 4, maybe 5 in the country. I happen to work at one, and we were really the ones that kind of started saying things like, we can help these people. And they have communication problems, not because they have a specific problem speaking. They sound like they are making sense, but they're not really making very good sense. So one of the things that I like to just share with people is that when you think to yourself internally, you think in words, right? You think in sentences. You talk to yourself internally as you're thinking about your day. That's language. That's speech pathology, right? This is a study we did here at Chapman a couple of years ago. We asked a group of students who had had concussion, and we asked students also who had musculoskeletal injuries. So the MSK means some kind of orthopedic or musculoskeletal injury. And we had created a survey for people with more severe brain injury that we used in Minnesota, but we hadn't really focused on individuals who had concussion or mild TBI. I thought, well, their experiences could be different. So The athletic training department was wonderful in helping us recruit, and we had a really nice sample size. I think we had about 50 in mild TBI and about 30 or so with musculoskeletal injuries. And so you can see that there is definitely differences in the groups. So in terms of those with mild TBI, many more females than males actually reported symptoms. Okay, and that's consistent throughout the mild TBI literature. There is some evidence that shows that there is a gender effect, that unfortunately young girls, women, are more at risk for having continued symptoms from a mild TBI than their counterpart male athletes. Again, girls, ladies, if we could just grow this neck here, just nice and thick. I know we're all trying to get slim looking, right? But we do think it's related to body type and muscles and muscular development, yeah. But you'll also notice, kind of the same pattern with the musculoskeletal group. However, the group with mild TBI reported many more symptoms than the group with musculoskeletal injuries. Why did we pick that musculoskeletal group? Because an injury is an injury. And anytime you're in pain or you've broken a leg or anything, you will have cognitive changes for a little while. But they go away, right? As you feel better, those changes, that fatigue goes away. You don't have the headaches anymore. But it doesn't go away for a lot of individuals with mild TBI. So this was an interesting finding. So we didn't find any big differences between the women that reported that they had had a concussion or mild TBI and had gone back to college versus the guys. So unlike, not all the literature says exactly what we expected to see, but this was the case here at Chapman. This is a really complicated slide, and all I want you, these are the individual items that we asked about, and all I want you to notice is that everything in red here is more than 50% or proportion of those with mild TBI reported that they had trouble with attention, fatigue, headaches, and this is again that same concussion group. But if you look at where these are reported for the musculoskeletal group, it's much lower percentages. 30 is the highest, 23. The other thing that they reported, of course, was that they went away. So this group reported that the symptoms they had just went away very quickly, whereas this group had a much longer recovery period. So what can we do in terms of professionals? What can we do to help? Well, first of all, interdisciplinary mild TBI or MTBI rehabilitation teams are available. They're available here in Orange County, in LA County, San Diego County, and all you really have to do is Google them if you know of someone who has some protracted or continuing symptoms. The other thing that we need to think about is providing a real personalized education about the injury and the recovery, and that's where that mild TBI clinic or rehabilitation team can really help out. It really isn't sufficient to just go online and look up, well, these are all the symptoms, and then, oh yeah, I have that one. No, I don't have that one. Yes, I have that one. That isn't particularly helpful. It may be validating, but if you go to a rehabilitation specialist who knows this particular kind of injury, they can really help pinpoint kind of where your loved one's symptoms may be. The other thing is that speech language pathologists and occupational therapists provide cognitive rehabilitation for these folks now, and we create individualized tools. We use metacognitive. Metacognitive is thinking about your thinking. We use all those metacognitive strategies to help individuals learn how to adjust to their life now with these challenges while they continue to recover. So we want to support them while they're recovering, knowing that For the most part, they will recover fully eventually. It may take a year, it may take 2 years. And then the other thing that we can do is to provide them support as they're out in the community. They're getting natural feedback from their family, from their employer, from their peers and friends. They're getting this feedback, and yet they don't have really anywhere to talk about that. Well, I didn't do this, or I messed up here. And so even though that helps promote somebody's self-awareness, like, oh my gosh, I thought I could do this, and I just completely flunked that exam. But if they have a place to talk, someone to talk to, who can provide them with, okay, well, let's figure out what we're going to do next time. Let's do this together. Then it's a little more validating. And of course, we want them to be more resilient, because there will, of course, be something else that will happen down the road, and the rehabilitation person won't be there to help. So what can be done? We, in our study, in our groups at University of Minnesota, as well as here, we really found that if rehabilitation professionals early on can focus on those time management issues and staying organized, then if they're college students or if they're individuals who need to get back to work, the learning something new, the stress and the anxiety, and the self-advocacy piece tend to follow. So we developed something called dynamic coaching. It's a form of intervention that supports and instructs individuals in the use of their own executive functions to be able to assess situations accurately and solve problems that arise. Because typically these are a lot of young adults, and they've got a future ahead of them, and they don't want a mild TBI necessarily to prevent them from meeting some of their goals. Well, if they're getting coaching support, if they need to change their goals, at least they're being supported to do that. And they're being educated about their own strengths and weaknesses, so that they can then learn to be kind of an advocate for themselves. So sometimes family members don't understand, right? Because the person looks so good, right? I'm not seeing any change. And yet the person themselves is learning, yeah, but I just have trouble paying attention in that situation. I need to wear my earbuds just for a little while. And, you know, maybe the parent doesn't want them to wear the earbuds because it looks weird. Well, you know, but the individual themselves is saying, no, I really need to wear my earbuds. This is what I have to do right now. So that kind of support from a coach is really helpful. The dynamic piece here reflects self-regulation processes that are ongoing and ever-changing with the student's needs, their situations, and their context. The last thing a rehabilitation professional wants is for someone to be in therapy for the rest of their life. We want them to be able to problem solve for themselves, to regulate themselves, to make their own adjustments, make their own decisions based on who they are now. These are just the 4 tenets of the coaching approach: to have a trusting relationship. It's a structure that helps model self-regulation. It occurs within a context. So it can be in a clinic, but the person needs to be at home where they're working on things that need to be done at home. If they're college students, they need to be at least trying to get back to school or in college. If they're wanting to be back at work, then taking some of their work activities and working on those work activities in the therapy session so that they can then learn what they can still do and where they're having trouble. Then they can also learn to advocate with their employer, because they can get accommodations, just as students with mild TBI can do that. So what can you do? Find out where your level 1 trauma team or your level trauma centers are. And that's only in case someone you know or a family member that you have has a concussion. Try to have them go to a level 1 trauma center. Why? Because they're more likely going to have in place the absolute protocols in the emergency room for traumatic brain injury. They will verify some kind of follow-up. They may even have a mild TBI clinic, or they can get the referral to the person. They often have interdisciplinary support. And you can also find free services. There are free services usually at university clinics in speech, language, and hearing programs. So I don't know if all the university clinics in SoCal are all free, but I think we're up to like 16 different clinics now. So we have 16 programs in Southern California in speech, language, and hearing. They all have a clinic on campus. So the other thing that you can just do is believe what they tell you. And try to be supportive and listen without giving too much advice. Accommodate around their symptoms. If you've invited someone who has fatigue and noise sensitivity issues to a party, make sure that they have a place, a location in your home or somewhere where they can just take a break. And don't make a big deal out of it, right? Just say, yeah, I mean, I had a party, someone came who had really fatigue issues, and I just said, well, bedroom's upstairs, go ahead, take a break. Boy, did that person ever appreciate that. And the other thing is, don't minimize or normalize what they're telling you. Sometimes people will just say, just the first thing, because they want to relate to the individual with a disability, they may say something like, oh, you're tired. Boy, I am so tired. Last night I was up so late, and I can barely function today. I'm pretty sure that's not the same, right? I actually had a client tell me once that someone had said to them, I would like to take a nap in the middle of the day. Wow. Yeah. It's not the same. The fatigue level, the symptoms, it's like the fatigue level is like hitting a wall. I had someone tell me, they were like a car and they were going really, really fast, and then all of a sudden they ran out of gas. And when that happens, you need to go rest right now. And then educate yourself. The CDC has amazing resources online. One for families, for healthcare professionals, for individuals with TBI and mild TBI. There is a really good organization online called Brainline. They have a lot of videos, and that's also very, very helpful. And then there is the Brain Injury Association of California as well. It has a lot of educational materials. And then, if you know someone with TBI or mild TBI, help them, be supportive of their advocacy as well. Here's some additional resources that you can look up. There's a really nice one on the American Speech Language Hearing Association website called a tool, a clinician's guide to cognitive rehabilitation, mild TBI. And then there's a recent publication by Pauline Machina and colleagues on how an interdisciplinary and interprofessional collaborative can work together to support people with mild TBI.